Okay, so a little bit after 1, we'll go ahead and get started. This is the Dementia and Antipsychotics in Long-Term Care Setting Quality Improvement Initiative, a partnership between Vanderbilt Medical Center, Vanderbilt Center for Quality Aging, and QSource. And this is our third in a series of 6 sessions, so you can see what's coming up. If you've missed the first 2 sessions or one of the first 2 sessions, you can view our website, project website. They have recordings from sessions 1 and 2. And you should see that email link pop up in your, or that web link pop up in your chat pane. Britt will be monitoring the chat pane, which should either be on the right-hand side of your screen or the top of your screen, depending on how it's laid out. We will have all the phone lines muted today during the presentation. If you have a question or a comment, anything, please send that to Britt through the chat, and we will respond to those. Either she can answer it in the chat or our presenter will answer it. And just to kick things off and to know who's with us today and that you can appropriately access your chat pane, please go ahead and type into the chat pane what facility you are from and how many people are viewing the webinar. While you're doing that, I'll remind you that we will also have polling questions today. So you'll see them pop up on your screen. You'll have 30 seconds to answer. Please make sure you hit the submit button once you select your choice. That's the only way we'll know your answer. So again, this is the third in our series of 6, and today is psychopharmacology in the nursing home. And we have Dr. Warren Taylor with us today. He is the director of the Mood Disorders Program in the Psychiatry Department at Vanderbilt University. He is a geriatric psychiatrist who specializes his research in depression in older adults and depression and cognition in older adults. And so we are very lucky to have him with us today. He is a great resource, so be thinking of questions for him along the way. And at this point, I'll turn it over to him.
Perfect. Thank you very much. So we have thank you all for coming. Thank you all for listening in. We have a number of objectives we really want to hit, and just to kind of briefly hit them, I want to give you a broad overview of how we think about psychotropic drug treatment of older adults, specifically in nursing homes. We'll address some on-label and off-label uses. We'll really be talking about how we need to be aware of these, again, in a nursing home or extended care environment, and really think about whether they're appropriate and inappropriate uses. And when we get to antipsychotics, we'll talk about a little bit of the regulations and what we need to be thinking about as we initiate their use, but also when we have to have a trial of coming off the medications. In general, I was always taught when I give a talk to give the kind of punchline first. And so I'm going to give you that, is that really pharmacotherapy, medication management, should not be the first thing you jump to in a case of behavioral disturbances in dementia. You always want to think about environmental interventions, behavioral interventions, and then when those are not working or you have a more severe case, then you think about pharmacologic. And in general, if you want to, when you do decide to initiate medications for behavior, remember monotherapy is an ideal, and it's a perfect ideal that unfortunately we don't often achieve. And polytherapy, polypharmacy is far more common. When we do this, we really need to carefully think about what we're doing. When we think about combinations, we increase the risk of bad side effects and adverse events. We always are at risk of people not taking medicines, refusing medicines, doses being missed. And in particular, what really bothers me is when I see people on multiple of the same medicine, so this rational co-prescribing. Why would you want to give people 3 antidepressants? That doesn't make sense. We need to think about rationally what we're doing, and if we're going to initiate a second or a third medicine, why is that, and what do we hope to gain by that combination, versus maybe, instead of adding a third, taking one off and putting a new one on, and so staying at 2. So we have to think carefully about what we're doing in all these cases. The reason why this matters is that really neuropsychiatric symptoms are really, really common in the older adult population. particularly the older population with dementia, which is the orange bars. And as you look, you can see we have a number of psychotic symptoms are common. We get into the depression, anxiety, other things like irritability, sleep and eating problems. But when you really look at all of it, 80% of people with dementia have some neuropsychiatric symptom. So these things are really, really common. And when you think about pharmacotherapy, I'm still struck by one of the lessons one of my professors taught me when I was in training. He said, when it comes to behavioral disturbances and treating it with medication, all the medications work sometimes, which means not nearly as often as we want. So it becomes a very real problem all of us deal with. When you think about how to select what behavioral problems might be most responsive to medications, think about behaviors that are fairly continuous and that you've tried behavioral interventions for that just don't work. So this may be non-aggressive agitation, maybe persistent anxiety, maybe some depression. We think about behaviors that occur in response to certain stressors. So people can become very agitated during bathing, during certain activities. Think about using a medication on a time schedule right before that activity. Something may help make that more tolerable for the resident. Or think about behaviors that really are very similar to other psychiatric disorders like the psychotic symptoms and so on, dementia. So let's just dive right into medications. I'm going to start at a place many people don't think to start, but thinking about the acetylcholinesterase inhibitors. So these, of course, are the medicines that are approved for the treatment of memory disturbance in Alzheimer's. We have the acetylcholinesterase inhibitors such as donepezil or Aricept, ribostigmine, several others. And although we mainly use it for the treatment of memory, there is good data to show that it actually can improve a number of other behavioral disturbances such as apathy, anxiety, and could even decrease the frequency of hallucinations. Now, they don't necessarily make these completely disappear, but if they can lower the severity or lower the frequency when this happens, that can still be a huge benefit. And to show that it is really a drug effect, there's been a study that we'll talk about that shows actually that if you then stop the medicines down the road, you're not sure it's really helpful, you stop it, these disturbances can get worse. And so this is just showing, I'm not going to show you a whole lot of graphs and studies, but this is one of them we wanted to highlight, showing that the yellow bar is Aricept or donepezil, a commonly used acetylcholinesterase inhibitor. And we look at what we call the NPI, or the neuropsychiatric inventory, which is a measure of a whole range of behavioral disturbances. Clearly, people on the drug over the course of 24 weeks did far better than people that just got a placebo or no medicine at all. When these investigators really looked at what domains of behavior were most affected, it was, as I said, depression, anxiety, and apathy. So it looks like it provides some good benefit. This is a subsequent study that, sorry, the figure got a little goofy, but really when you see that everyone had donepezil for the first 12 weeks, and when the arrow is pointing down, they were randomized to either continue on donepezil or Aricept or go to placebo. And the group of placebo, obviously their behavior got worse. So it makes a good argument that, when you use these medicines and people have a history of behavioral disturbances or might have sporadic behavioral disturbances, we then scratch our heads and say, is this really helping? The answer is often, yes, it is. And so if there's a good reason to stop the medicine, that's fine, but we should monitor how that person's doing to say, do these disruptive behaviors, do they get worse? Was the medicine doing more than we realized? So the following question is, acetylcholinesterase inhibitors may help memory and cognition, but they do not help with the behavioral disturbances. Is this true or false?
There we go. There's the question. And make sure you hit the submit button after you select your answer. Okay, so
So we had 1 true, 2 falses, and 6 no answers. Come on, no answers. We can do better than this. So the reason I put this in there is the question there is because I really want to emphasize these medicines can have a benefit. They're not going to be used for somebody who's acutely agitated. This is not an as-needed medicine. This is not for someone who's having a problem right this minute and you need control over. But in the long term, in the long haul, and reducing the severity and frequency of some of these behaviors, these can be quite helpful. Very good. Let us move right along. Okay. So now antipsychotics. And there's a lot of points I want to make with this. So let's first, the indications we usually think about are psychotic symptoms, hallucinations, they see something, they hear something that isn't there, delusions, they're believing something that isn't real, but also, of course, aggression. We can occasionally see them used in people that have very severe anxiety, or, as we'll talk about a little bit later, treatment-resistant depression. When we use this for behavioral disturbances, honestly, the experience of many of us is the efficacy is modest rather than striking. You're not going to use a little bit of this medicine and have, the sun come out and a miracle cure. You have a modest reduction of what happens. And in some cases, this can actually worsen behavior. And I want to use this as an example. This was a case I still think about from my own training, was a gentleman that was brought to the emergency room for increasing levels of agitation and aggression. And as the story goes, this was a number of years ago, so he was put on haloperidol, an old antipsychotic, and he had been somewhat aggressive and agitated, so they put him on a little bit of medicine. One of the side effects of these medicine is a side effect called akathisia. That's a fancy way of saying it makes you feel very, very restless. You can't sit still. You have this strange, uncomfortable urge to move around a lot. And that's what happened to him. So he started pacing more, getting more agitated, and of course, what did the nursing home do? They gave him more Haldol. He got worse. They gave him more. Now he couldn't lay down. He'd gone several days without sleeping. He was so agitated, and he went to the emergency room. We admitted him, stopped the medicine. He got much, much better. So keep in mind that medicine can have strange effects you don't anticipate. Other effects we see, extrapyramidal symptoms. They get very stiff. They get very slowed down. They can sedate and confuse, but can also cause their own problems, of course, and can have some cardiovascular effects, cause arrhythmias and other heart problems. And the other take-home message is there really is an increased risk of death. I'm not going to spend a whole lot of time talking about this very complicated table, other than that very first column under the blue. We're looking at all-cause mortality. And so if you look at the different drugs in blue, these are a whole range of commonly used antipsychotic medications. And the take-home message is that all of them, we compare to people without antipsychotic medications. If we compare to people without medications, all of them have higher rates of death in the first 180 days after starting the medication. So the first 6 months after starting this, rates of death go up. And what I really want to emphasize is this, where haloperidol, one of the older medicines, has a much higher rate than we see with some of these newer medications. So we can feel more confident that our newer medications are safer and better tolerated, and that's absolutely true, but it's not like they have absolutely no risk at all. So these medications do have dangers. Now, with older guidelines, these medications for a long time were, for better or worse, used as chemical restraints. And so we now have federal regulations about what we can do and how we should use them. And by and large, we should only use these medications if they exhibit symptoms that impair functioning or put them causing danger or at risk of danger to themselves or others, or that somehow interfere with their provision of care, taking care of them. Simply being agitated is not a sufficient reason to use them. There needs to be something else. Are they aggressive? Is there a threat? Is it interfere with their care? Are they psychotic? Are they hallucinating? These are things that qualify for their use. And the key thing is document, document, document. It is considered these medicine uses are unnecessary if you have not documented that you're using it for the appropriate indications. And I usually advise people to document other things you've tried. So if you're being aggressive and agitated, document if you've tried to do other things first. That will only help your case if you get audited. And again, it just requires an approved diagnosis and approved symptom. When should you not use them? There's a whole slew of times people used to use them that you should not use them if this is the only symptom, wandering being a common one. Antipsychotics, they make people sleepy, they will not stop them from wandering. You can see that looking for self-care, anxiety, depression, when it's uncomplicated, insufficient, fidgeting, nervousness, agitation, when there's no danger, these are not sufficient causes according to the regulations. Allowable diagnoses, by and large, are focused on cases where there's a psychotic symptom. So again, the hallucinations or delusions. You see all the schizophrenia and associated symptoms. You see under psychotic episodes. It is allowable in Huntington's and Tourette's disorder, two very specific neurologic illnesses where antipsychotics may be particularly helpful. And in defying the laws or the regulations, organic little syndromes, meaning dementia, and certain criteria are met. We'll talk about the criteria in a second, but I just want to hit briefly what these antipsychotics are. Some of the more common ones we see used are olanzapine, quetiapine, and risperidone. I think the take-home messages to be aware of in providing care for people on these medicines is that they are not your friend if you're interested in weight gain. They all cause some degree of weight gain to one extent or the other. Olanzapine being one of the worst culprits for weight gain. They all cause sedation to some degree. Quetiapine, Seroquel being the most common culprit for that. And then we have other medications such as aripiprazole that are less sedating and have less weight gain. Ziprasidone when there's less data. And clozapine. Clozapine is an older agent and still one of the more effective antipsychotic medications we have. It's particularly useful for people who have neurologic illnesses where they can't tolerate other antipsychotics, such as Parkinson's disease, where if we give one of the standard antipsychotics, it may worsen their Parkinson's symptoms, and then they get stiffer and slower and have a harder time moving. The one key I want to show with that is that this is a complicated medicine. It has some serious effects on our white cell count and our immune function. And so at least when you start it, you have to monitor it weekly. So you have to have a weekly blood draw to make sure your immune system isn't shutting down. Once they've been on it for several weeks and months, then you go to every other week. But it involves a lot of monitoring. Now, if you have someone who is on these medications and for a good cause, say they have schizophrenia, they have bipolar disorder, well, actually we'll get to that in a minute, schizophrenia, there's dementia with aggression, dementia with psychosis, we do have rules that we have to have a gradual dose reduction every 6 months. So the intent of the regulations is that you don't want someone to be put on one of these medicines and left on it forever when they may not need to be on it forever. We know that in dementia, these symptoms can fluctuate. And someone may be very aggressive today, but 6 months from now that may not be the case, or at least not the case for everyone. And so the idea is that every 6 months you want to have a gradual reduction to see can they tolerate a lower dose or can you get them off the medicine. If you can't, you document it, you go back to where you were before. That's a good rationale to continue on the medicine. Now you have to do this every 6 months unless a patient has one of the 10 approved conditions, say schizophrenia, dementia with psychosis, something in that range. If the diagnosis is an organic mental syndrome, which is a very broad diagnosis that kind of does fit within the idea of dementia. Plus, you've tried to do it in the past. So they have one of those symptom diagnoses, and you say, we've done this a couple times in the past. It's not gone well. We feel they need to continue on this indefinitely. In this case, document, document, document. What is the diagnosis? What are the symptoms you're targeting? What other diagnoses could you be considering? And is there a role for other medical illnesses, and what is the risk-benefit? Someone who becomes very, very aggressive or becomes highly psychotic when you take them off their medicine, clearly the risk of staying on that is going to be counterbalanced by the fact that when they're in that acute ill state, you can't take good care of them. Or their behavior interferes with other things you need to do to help maintain their safety or good treatment. So that's just obviously not going to work, but documenting. Again, in case of an audit, that will only be your friend. The next point I want to make is that, these medicines, even when you think, oh, I don't want to take people off them, why do we want to go through this? Well, the reality is a lot of people come off these medicines anyway. So this is from a study that was done a number of years ago called the Katie study. And this is mainly done in schizophrenia, but they had another arm of the study done in people with Alzheimer's who had psychotic symptoms. And the gist of the study was they were really looking to say, do any of the antipsychotic medicines we use actually help improve psychotic symptoms in this population in a very large group, so not at the individual level, but broadly. And as you see, they use a lot of medicines that we've been talking about, and they have a placebo, so some people didn't get medicine. The short version is the study did not show any drug effect of any of the drugs. That no drug was better than placebo. We were all very surprised by this. But then, again, if you stop and think about it, we've seen plenty of people we treat that have Alzheimer's or psychotic symptoms. They give them these medicines, they just don't respond. So maybe we shouldn't have been so surprised. So this is looking at just how you treat people and you see what happens. They knew what when do people come off the medication? And so this is looking at weeks. So people on this for up to 10 weeks at a time. And you see, basically, if you let people and their caregivers do what they wanted to do, after about 16 weeks, over 70% of people had stopped the medication. Why is that? Well, a number of them had stopped it because it just wasn't working. And this yellow is the placebo arm, so unsurprisingly, they stopped the medicine faster. But with the other antipsychotics, again, over almost 40 to 50% of them have stopped the medicine at 16 weeks because they felt it was not helping the problem. And then, if we look at tolerability, well, not very many people stop the medicine because they have problems, if you're in the placebo arm, but clearly a good 20 to 30% of people stop the medicine because they have side effects. So when you add all these numbers up, people stop these medicines at very high rates, either because they can't tolerate them or because it just doesn't work. And I think, to me, this really captures the challenge in treating these behavioral disturbances in this population. It's not an easy job. So let's go to the polling question. Antipsychotic medications are required to have a dose reduction and withdrawal plan in place. True or false?
There we go. So check your answer and make sure you hit submit.
We should really have Jeopardy music. More participants. Great. We're doing better. 60% of you said true, which is correct. One of you said false, which is incorrect. And 3 of you still didn't answer. Let's see if we can get to 100% participation by the end. The answer is true. When you start the medication, it needs to be done thoughtfully. And you need to have a plan to say, we're going to try to get our resident, our patient, at the lowest possible dose or off the medicine within a reasonable time frame. And I think you need to go in this with open eyes. And some people that will work and they will do well off the medicine. Other times it will not and they'll need to go back on it. But at least you've had a plan and you've answered the question, do they need to continue on the medicine? In that case, the answer may be yes. But for the residents, the answer is no, and they do well with it. That's wonderful. That's great to get them off these medicines that have very serious side effects and an increased risk of mortality. So fantastic. Let's talk about antidepressants and dementia. And I want to start with an odd one, trazodone. So most of us who use trazodone in my clinical practice, I think about it with sleep. And, I use this in my younger adults as well as my older adults. It is not a great antidepressant. It is a fantastic sleep aid. It does not create dependence. No one has ever gotten addicted to trazodone. And it does a nice job. There's also a role for it in the treating of behavioral disturbances. And so if you have anxiety-related agitation or episodes of aggression or sleep disturbances or in some cases vocalizations where people are calling out and yelling, it can be very helpful. Now, trazodone has a very large therapeutic range. You know, when I use this with my younger patients, I'll use 50 to 100 to 150 milligrams. If we're starting this in older adults, particularly older adults with memory impairment dementia, you'll want to start low. And 25 milligrams, sometimes even less than that, 25 to 50 is a good place to start. And you can use this as a PRN. You can use this as needed medicine. You can use it as a medicine to give them right before, you know, a time when they may get upset. So if they get upset when it's time to help them assist them with their bathing, you give this to them a little bit beforehand, it may smooth that process out a little bit. It has a short half-life. It doesn't stay in their system for very long. And you can combine it with other medicines, with the antipsychotic medicines, with other antidepressants. It's a medicine that is fairly well tolerated, with the one exception of people who have serious heart disease. If they have a lot of arrhythmias or other heart disease, this one, especially the higher doses can cause problems, may be best to avoid. Now, of course, that's one medicine. We have a lot of other antidepressants. This is a very commonly prescribed drug in many residential living facilities. As a whole, they are effective for the treatment of depression, also can be very effective for anxiety, but can also be useful for a whole host of other behavioral disturbances, irritability probably being the most common one, can help with hostility, can help with anxiety, as I mentioned, and in some cases, can help with vocalizations. Now, depression, I mean, the people, you all know as well as I do, depression is a very prominent problem in assisted care living facilities, in nursing homes, and residential care facilities of all kinds. And sometimes the antidepressant does not do as good a job as we want. We do know we can use it in combination with the antipsychotics as well as other cognitive enhancers like the ribofigmine, and other things. And I wanted to talk about antipsychotics because this has been actually a change in our clinical practice over the last 2 years. Some of these newer antipsychotics we've been talking about appear to have significant efficacy to help improve depression in people that don't do well with the usual antidepressants we start. So you start them on sertraline, or citalopram, or venlafaxine, any of these, and they may get a little bit better, but they just aren't doing well. There is some role for some of these medicines, and aripiprazole, or Abilify, is one that's approved by the FDA, for treatment-resistant depression. So I think there is a role for this in many, many environments. We have new data that they are safe and effective in older adults. But again, I think you have to be very cautious in how you document it, and why you're using it, what the target is, and then you are, in that case, using it for an FDA-approved indication. So I think documentation is critical in this. I think that there is a role to say, even in someone that does well, can they come off the medicine down the road and still do well? So, you know, often we think about antidepressant medicine, they stay on long term, and in many cases they have to. But there are some people that if they may improve on something like aripiprazole, and they've been doing well for 6 months, maybe it makes sense to give them a trial off the medicine, just as you would for any other indication. That may be a very safe thing to do if the depression returns. I think you'd be on firm ground to say, well, we did our best, the symptoms return, or we start the medicine, again, for FDA-approved indication. And I think you'd be on firm ground for use in those ways. Antidepressants also have risks, and this is something I want all of us to think about more. Very recently, the serotonin medicines like sertraline, fluoxetine, citalopram were put on a Beers criteria, which is a list of medicines that should be avoided, if possible, in older adults. This was pretty controversial in the psychiatry realm, and it was really over concern that use of the serotonin drugs may be associated with a higher risk of falls and a higher risk of fractures. Just about at the same time, although it wasn't part of the rationale to go on the Beers list, there's some data to show that people that are older adults on antidepressants may be at a slightly higher risk of stroke. These are both very, very serious side effects we have to take very seriously. But I think the way I think about this is being acutely depressed is also very serious. And if they're not engaging in physical therapy, if they're not engaging in other activities they need, if they're not eating, that's going to lead to bad outcomes as well, number one. Number two, the criticism of these studies is that they're comparing people on antidepressants with people off antidepressants. Well, depression has a higher risk of stroke. And if you're depressed, does that lead to higher risk of falls and fractures and other things? I don't have the answer to that. But what is related to the medicine and what's related to the underlying illness is the main question. I think the way I'm very pragmatic about this, when I give this to my patients, we talk about this being a risk, so then I'll emphasize, you're very depressed, and this is why we need this. And again, I think these are risks we have to accept and be aware of. And certainly, if we're in a residential setting, if you're adding on a new antidepressant, maybe being a little bit more vigilant as you're going up on the dose, and they're starting to say, are they looking more unsteady? Is there a little bit risk of fall? Maybe pay a little bit more attention to that. When we think about using for agitation, we talk about trazodone, used for some of this agitation and anxiety. And again, the SSRIs we think about using for irritability, vocalizations. And again, start using a very low dose. I mean, lower than you expect. For trazodone, we talked about that lower 12.5 to 50 milligram dose. You use it multiple times a day if you need to. If you don't. The serotonin drugs, which is, again, a good one to start at, despite what I just told you. We usually start at a quarter to half a dose. And, go slow. Don't be afraid to go to higher doses. You may need it. But definitely go slow. Don't hit them over the head with it right out of the gate. So polling questions. Antipsychotics should never be used to treat depression in the elderly. True or false?
You've got about 15 more seconds, so select your answer and make sure you hit submit.
Come on, 100%. So we have 40% say true, 20% say false, and 40% say no answer. Oh, not as good as last time. So the answer is true, but I think this is an area that is made to some extent be a moving target. The FDA indication for aripiprazole, that one antipsychotic I mentioned, is in the grand scheme of things fairly new, and it's certainly newer than the OBRA guidelines for how we use antipsychotic medication. And so it's, again, I think it's a reasonable thing to do with appropriate documentation, but certainly it's not the first thing out of the gate you should try. Try more conventional antidepressants. Use those. If they work, great. If they don't, then I think use something like aripiprazole according to its indication. Great. So now we're going to talk about a couple other medicines and shift into some other medical issues that may complicate the picture. Anticonvulsants. These are medicines that have been long used for the treatment of bipolar disorder or manic depressive illness. So we talk about things like Depakote, or valproic acid or valproate. Lithium, although lithium is not an anticonvulsant, of course, has been long used for bipolar disorder. And honestly, the data of how we can use these medicines for behavioral services, the data just aren't very good. Anecdotally, I mean, I think if you talk to many of us, we've seen people that have done beautifully on these medicines. And, some of the data that we have support it. So using valproate as an example, valproate, some small trials supported efficacy, some larger trials, wasn't so sure to do it. Anecdotally, again, I've seen people that have done wellness medicine and benefit from it. It's nice. It's not an antipsychotic, so you free yourself from those regulations. The dose you start at, this is a fairly low dose, twice a day. If someone is not from other medicine, there is a liquid formulation. There are sprinkles. Another formulation that make life a little bit easier. And this is a medicine you can actually measure blood levels in. And so if you're worried someone isn't doing well, check the blood level. Is it look very, very low? You don't want to treat the blood level. So don't increase the dose because the blood level looks low. Go by how they're behaving and the symptoms you're targeting. But on the other hand, if you say the medicine hasn't done much for them so far, maybe they need a little bit of a higher dose. And I think here we really see this used particularly for agitation. And kind of those residents or patients that seem like they're always moving around, maybe agitated, may have high levels of energy, sleep may be an issue for them, things you'd expect to see in someone who's manic, where they have high levels of energy, maybe talking excessively, may not need to sleep as much. And so we're trying to use symptoms in a dementia patient that may to some degree mirror what we see in someone with bipolar disorder. And that may be an cue to say maybe this is something reasonable to try. Benzodiazepines. This gets to be fairly controversial, and many of us hate using benzodiazepines, but every so often we need to use them. And it can be useful for very short-term management when you see high anxiety, or if you really need rapid control of agitation, when really there may be a risk issue, they may be very escalating, and need something to help calm them down quickly. Use short-acting agents like lorazepam, use low doses like 1/4 to 1/2 milligram, and really, as best you can, don't do this regularly. Regular use of benzodiazepines is really, really problematic. Sedation being the most common side effect, but it can also disinhibit people. You can actually give them these medicines and make the problems worse. The easiest way to think about these medicines is equivalent to thinking about having a beer, or 2 beers, or 3 beers. Most of us, if you've had a beer and you're feeling tense or anxious and you have a beer, you feel better. Your anxiety lessens, you start smiling, you feel better, you feel more relaxed. But then if you have, say, 2 or 3 beers, then you start doing things you later regret. And benzodiazepines are actually very, very similar. A little bit of a dose may go a long way, may make them kind of tired and sleepy. You give them more and they're disinhibited, and now they don't want to go to bed. They want to stay up and do things. They want it. So be aware that a little bit goes a long way. It also has a lot of risks. Of course, these medicines have a strong risk, and they can, again, think about what does beer do? Any alcohol do? It slows down your reaction time. It makes you stumble. It increases your risk of falls. It makes you a little bit more confused. Benzodiazepines doesn't do all these things. And really, again, if you fall, as you know, falls are bad as population. Hip fractures can be a death warrant for many, many patients. Long-term use, if you use it chronically, it does seem that it associates with a longer-term risk of further cognitive decline, and then you have to get them off it. Benzodiazepine withdrawal is a very serious medical issue. People are admitted in the hospital to withdraw them off the medicine safely. If you're on a medicine at a high enough dose for a long time, and everyone's different about what that looks like, they can have withdrawal seizures. So it's a very serious thing to try to come off of. Do we have a question? Oh, sorry. We move from there into sleep aids, and I'm going to give you a slightly different message. Sleep aids, by and large, with the exception of trazodone we've been talking about, carry some of the same risks. Many of the sleep aids, like Ambien, for example, that people have heard a lot and seen a lot about, work very similarly to the benzodiazepines. And so we've appropriately been concerned about a lot of risks that falls with this class of medicine. What's interesting, some of the sleep specialists have highlighted, is that insomnia itself is associated with falls risk. And so I don't want to get into all the gory details, but if you see here, this is looking at a number of people looking at variables that may be related to falls risk over a lot of people. And if you have insomnia in a supervised living facility, your risk of having a falls goes up. And actually using a hypnotic or a sedative, that goes up too, but that's independent of insomnia. So it seems to me, and again, the sleep specialist will tell you this, that it's not so much taking a sleep aid is the biggest risk, it's the not sleeping. And if you're not sleeping, your risk goes up. And what's really bad is if you're not sleeping and taking a sleep aid, that's a 1-2 punch. So if someone's on a medicine for sleep, we need to make darn sure they're staying asleep. So insomnia is not your friend. And it makes sense. Most facilities, the lights are down low, things are a little darker, people may be on some baggier pajamas, we're less well-staffed at those times, and so it makes sense that environmental variables may play a big role that may contribute to this falls risk, even without a sleep aid. Moving into some medical issues, pain control. Just because we develop memory impairment doesn't mean we don't feel pain. And it's, pain medicines have a negative effect on cognitive performance, have a negative effect on memory. in many cases, but also untreated pain can be a really big issue in exacerbating behavioral disturbances. Think about it. If any of us are hurting, are we going to be the most pleasant person in the world? No. We're going to tend to be more irritable, more short-tempered. People with dementia and memory impairment are no different than that. So it can produce irritability, agitation. There was a study came out that routine prophylactic Tylenol use, which I don't know if I'd recommend. Tylenol has its own issues. But it can result in improved social interaction and ADLs. And really, if you think about people who may have a good history of chronic pain and you think they're undertreated, does it make sense to try increasing their pain regimen and say, does this improve the behavior? And this was a study done a few years back looking at a stepwise, more complicated pain protocol management and showing really clearly that people that have better pain control, their agitation levels go down. So again, it's not getting to zero. It's not like all the agitation goes away, but it makes progress. And if someone has pain, I'd rather treat that than put them on any psychotic and leave the pain untreated. Constipation. This is oddly one of my favorite topics as I teach many people. It's amazing, again, constipation is not fun, again, causes a lot of pain. And if you don't pay attention to it, you lose track of it. And it's amazing how many people I've seen admitted to psychiatric facilities for agitation and aggression, and as soon as they have a bowel movement, they become the sweetest person in the world. Unfortunately, we cause this. A lot of the medicines we give may cause constipation. So I really encourage you guys, I hate to say count the bowel movements, but monitor it. If people go a few days without something, maybe they need to have something to help move things along. You may solve a lot of problems that way. Finally, I want to touch briefly about delirium. And so to explain just the brief definition of delirium is this is a change in people's mental status that can show up in their memory, they can show up in their behavior, really anything that's related to some medical problem somewhere else. So someone gets a urinary tract infection and becomes more confused or more agitated. Someone has a pneumonia coming on and becomes more agitated, more confused. Maybe he's now sleeping 20 hours a day rather than the previous 8 hours a day. These can be hard to distinguish from dementia. And I wanted to highlight a couple key things here. The key thing is dementia, of course, is a slow change. They don't suddenly wake up one day and have horrible memory impairment. They don't suddenly wake up one day and are trying to beat up every person they see. That's a delirium, a very sudden acute change, acute onset. Another thing is how do the symptoms look? With delirium, it fluctuates. You may see the day shift says, oh, Mr. Jones looks great, he's behaving wonderfully. The night shift says, it's been a disaster. He's aggressive, he's confused. Again, when you hear the different shifts say, we're seeing a very different person, think about the delirium. A dementia is going to be far more consistent. He's confused in the morning, he's confused in the afternoon, he's confused in the evening. The delirium has marked psychomotor changes. They become very, very agitated and moving around a lot more, can be very hyperactive. This is often confused with depression. They don't get out of bed, they just want to roll over and sleep, they don't interact with you a lot. Again, a depression won't have quite such an acute onset. With dementia, it's far more slowly. You're thinking about changes over months, not days. And then, again, their consciousness is altered. Sometimes they're more conscious, sometimes they're less. And consciousness is not really affected in dementia. Their alert, it may be their memory is just not as good as it was. And I guess what you do with the delirium is you need to really say, okay, as we're thinking about how to manage behavior safely in the short term, what is the medical issue causing this? And so as much as you need to call a psychiatrist to help with the delirium, calling the internist or family medicine provider and say, hey, we think there's something going on here, maybe a delirium. We don't know what's causing it. We need to maybe think about a little bit of a workup. So to kind of wrap us up and have a summary, we have various classes of medicine, what they may be used for. Antidepressants, again, for irritability, anxiety, low mood. Antipsychotics for the psychotic symptoms. Anticonvulsants maybe for some impulsivity or hyperactivity. And then we have some things like irritability and aggression that may have a nice overlap. Keeping in mind that trazodone can be very helpful especially for anxiety or some well-timed use of medicine for when there's a trigger for the behavioral problem. Think about for analgesics, when they seem restless, when they seem combative, when they really seem to be uncomfortable and in pain. And when in doubt, the cholinesterase inhibitors may be a very reasonable thing to do that may help both memory and behavior as well. So really think about if you're going to use multiple medicines, let's be rational about how we do it. And again, to kind of come back to the point I started with, that these behavioral problems are the most biggest problem we deal with in dementia. Start with the environment. What medical issues are going on? Is there the environment with what the patient's doing, how we interface with him or her that may be contributing? What can we do to change our behavior, how we handle them? The example I always use here is, as you all have probably seen as people go back and forth from the hospital, God help you if you have vision impairment or hearing impairment. But that's what happens. They go from home to the hospital, they go from the hospital to a assisted care facility, and they go back to the hospital and back. If they have glasses, if they have a hearing aid, they're all gone. They're lost somewhere, who knows where they are. And so now you have someone here in your facility that can't see very well and can't hear very well. And if you think about using an example of a trigger that may trigger bad behavior, you can imagine if you couldn't see well and hear very well, and all of a sudden you're sleeping and kind of comfortable, it's 8 in the morning, and someone rushes in your room, turns on the light, tries to get you out of bed to go eat or give you a bath and starts taking off your clothing. I don't know about you, but I would probably be a little aggressive myself. And so it's always worth thinking about, can we ease them into whatever we need to help them with? Or did their glasses get lost? Is their hearing aid battery dead? Think about these things that may be playing a role with if behavior is changing. And once you've ruled all that out and say, this just is not it, then you think about the pharmacologic interventions. Brief summary, again, these medicines all have risks. Medicines do have a role, but we need to really reevaluate their need. And if people have been doing well for a while, think about coming off. Reducing dosage is always important, particularly for antipsychotics, and don't ignore some of these things. And then we can open it up for other questions, and just reminders that my colleague, Dr. Newhouse, will be giving this same talk tomorrow for anyone who's interested.
If you have questions, please send them to Britt through the chat pane. If you have other people at your facility who'd like to hear this presentation, the date and time, or the time for tomorrow is 10 a.m. Eastern. No, 10 a.m. Central Time, 11 Eastern. And also, to go ahead and give you the dates for session 4, I like that Dr. Taylor spent a lot of time today talking about documentation and trying non-pharmacological approaches first, because next month we will really dive into that, and we'll have a geriatrician and a geriatric nurse practitioner here to teach you how to document and try those approaches. Do we have any questions? And Britt will feed you through this chat pane too. We have a new project Facebook page where you can like our page, connect with some of the other people participating in the webinar series, as well as the speakers. You can send us questions through there, find information and links to our website and other resources. And we will be doing a raffle at the end of the webinar series, and more explanation will come on that, but if you engage with our Facebook page, you'll get more chances in the raffle. We have a question. What are your thoughts on using Haldol for end-of-life care? We have doctors here who use this frequently.
So I think haloperidol is obviously an older medicine, and it's still for really acute aggression, and it's still one of the standards often is used. And so very often when you see emergency psychiatry, people go to the emergency room and are really and not just agitated, but very out of control aggression, that may be an easy, quick medicine to use that can calm people down very quickly. I think, in my opinion, a lot of physicians have a lot of comfort with it. It's definitely more affordable, so if you're thinking about cost, it's cheaper than a lot of the other newer medicines. But it does have different risks. I think that there's a greater risk of, when even at end of life we talk about this, and we're not worried about the longer-term risk of tardive dyskinesia or the slowing down. But at the same time, I'm a little leery of giving a medicine that may hasten mortality, so to speak, and that is the risk of all the antipsychotics, but Haldol does seem to be a little bit of a worse offender. So I have mixed feelings. I think if it's something where you're treating psychotic symptoms or long-standing problems, I really recommend to the newer agents. If it really is for some aggression and it really is end of life type things, it's probably okay, but it's not my favorite. I know that maybe isn't the best answer, but I think it does have a role. But the more I encourage people to shift to the newer agents, just because they're so much better tolerated and the mortality risk is lower. You're welcome.
If we can get our WebEx host to post the final evaluation question, you can still ask questions through the chat. We'll be here for a little bit longer, but if you do need to sign off, please do the evaluation question first. And again, here is my contact information and Britt's contact information, as well as our project website address and center website address. If you have a question for our presenters after today, please do not hesitate to contact us. We'll be more than happy to answer your questions. And if you have no more questions and you've completed your evaluation question, we hope to see you back at session 4 in January, the start of the new year. As I said, we'll have a geriatrician and a geriatric nurse practitioner with us to really delve into the non-pharmacological approaches and how to document what you've tried and what has worked and what isn't working.